Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Ashwani Singal, Professor of Medicine at the University of Louisville. I welcome you all to this clinical clips from the Liver Meeting 2024. This is day one of the two recordings. So in this video, we have four abstracts to present. The first one is, this is a secondary analysis of patterns of pruritus change in the response trial. In this particular study, the authors wanted to evaluate trends in the mean NRS, which is numerical rating scale, over time and change in pruritus using various thresholds for improvement. So from the response trial, 72 patients had a baseline NRS of 4 or higher, out of a total of 193 patients recruited and enrolled in the response trial. 49 of these 72 were on seladelpar in the original study and 23 in the placebo. Higher at baseline, seladelpar reduced the mean itch intensity from moderate to mid from months 3 through 12. However, the itch intensity measured by the NRS scale remained moderate for placebo-treated patients and did not significantly change. Sub-analysis, baseline NRS score of 4 or higher, there was a higher proportion of patients on seladelpar versus placebo who achieved a 3-point or more reduction in NRS score at 12 months. The numbers were 47% versus 22%. Similar figures for 4 points or higher NRS decrease were 31% versus 9%. There was near resolution of itch, that means NRS score of 1 or lower was observed at month 12 in about 27% of patients who had NRS score of 4 or higher, and about 19% with an NRS score of 7 or higher at baseline and who were treated with seladelpar. However, near resolution of itch did not happen in any patients who were in placebo in the original trial. So the authors conclude that seladelpar reduced pruritus severity in PBC patients, and the effect is durable over time and even led to near resolution of itch in some patients. And this was not observed with placebo. Seladelpar also mitigated the new onset of itch in patients who did not have pruritus at baseline. Overall, safety was documented of seladelpar in this particular observation. The second abstract, which talks about long-term efficacy and safety of elafibranor in primary biliary cholangitis, and these are interim results from the open-label extension of the ELATIVE trial up to 3 years. Remember, ELATIVE trial was elafibranor versus placebo in a randomized placebo-controlled fashion for up to a year, and this is open-label extension for up to 3 years of data. And we know that in the original trial, elafibranor as compared to placebo was significantly more effective in improving alkaline phosphatase and also pruritus, which led to the approval of this medication early this year. And in this particular study, the objective was to report up to 3-year interim results from the ongoing ELATIVE open-label extension. Patients who completed the ELATIVE double-blind placebo-controlled trial were entered in the open-label extension to receive elafibranor 80 milligrams per day. The biochemical response, which was defined with alkaline phosphatase less than 1.67 times upper limit of normal and bilirubin below upper limit of normal, was observed in about 51% at week 52 of patients who originally received placebo and crossed over to receive elafibranor in the open-label extension. And this number was 85% at week 156 or 3 years of patients who originally received elafibranor and continued in the open-label extension on the active drug. Similarly, alkaline phosphatase normalization occurred in 16 and 39% respectively in the original placebo and crossed over to elafibranor and the original elafibranor treated patients. Measures of pruritus measured by PBC worst each numeric rating scale, PBC 40 each domain, and 5D each, also showed improvement in patients who crossed over from placebo to elafibranor, similar to those receiving continuous elafibranor. So the measurements now are similar to those who are getting elafibranor. And up to 156 weeks of receiving elafibranor, there were no new safety signals which were of concern in this particular observation. So the authors conclude that the ongoing ELATIVE open label extension, elafibranor led to sustained improvement in biomarkers of cholestasis and pruritus, with stabilization of surrogates for fibrosis measured by liver stiffness measurement and ELF score up to 3 years of receiving elafibranor. The drug was very well tolerated up to 3 years. Patients who crossed over from placebo had similar results at week 52 after converting to elafibranor. As we know that fatigue is a common but a debilitating symptom of PBC, and 20% of patients report significant or life-altering fatigue in PBC patients. The objective of this study was to assess the impact of long-term elafibranor treatment on patient-reported outcomes for fatigue and sleep in patients with PBC who were on open-label extension of elafibranor. Patients who were initially randomized to receive elafibranor in the ELATIVE trial without an intercurrent event and without missing data at baseline, and the time point of interest were included in the analysis. At the time of this data analysis in June 2024, 48 patients had data available at baseline and also at week 104, and 26 patients had data available at week 130. In patients with moderate to severe fatigue, the proportion of patients with improvements more than or equal to the minimal or MCID or minimal differences at week 104 were 56, 50, and 69% respectively. Similar figures for week 130 for the PFSF7A measurement for fatigue, PBC 40 fatigue measurement, and ESS sleepiness score measurement were 78, 58, and 50% respectively. From baseline to week 104, improvements were seen in the proportions of patients reporting normal or mild fatigue and normal sleepiness. So the authors conclude that the long-term treatment of elafibranor in the open-label extension results in clinically meaningful improvement in fatigue and sleep in patients with PBC who had moderate to severe fatigue or excessive sleepiness at baseline. Further, greater improvements were seen in those patients with moderate to severe fatigue or excessive sleepiness at baseline. My last abstract, which talks about long-term efficacy and safety of open-label seladelpar treatment in patients with PBC, and these are interim results for up to 3 years from the ASSURE study. We know that the ASSURE study is an ongoing open-label long-term phase 3 trial of seladelpar in patients with PBC, rolling over from placebo-controlled phase 3 response trial or with prior participation in legacy seladelpar trials. There are a total of 337 patients which are analyzed for this particular observation. Improvement in alkaline phosphatase levels were seen as early as first month, and these were maintained through 2.5 years or 30 months. Normalization of ALP increased to month 12 and were sustained in 41% of patients through month 30. Among patients who had elevated ALT at baseline, it normalized in 61%, 66%, and 90% of patients at months 12, 24, and 30, respectively. The authors also measured the composite biochemical response, and this was observed in 73% and 81% of patients at months 24 and 30, respectively. By 30 months, seladelpar resulted in a durable and sustained biochemical response in 81% and alkaline phosphatase normalization in 41% patients, as concluded by the authors. Seladelpar continues to appear safe and well tolerated, showing no new safety signals or changes in frequency of adverse events after up to 3 years of exposure. So thank you for your patient listening of this first clip and joining us for day one. You can please refer to the landing page for slides and to claim your continuing education credit. Please be sure to come back tomorrow for our second clinical clip from the liver meeting of 2024, in which we will present 4 additional abstracts. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.